Good morning, everybody. I hope everyone's got coffee. And as people have heard, we're recording this. This is going to be put on our web, and we're actually doing this. I have an acknowledgement slide at the end with support from some associates, but especially the Mann Foundation and the FAR Fund, and it's an effort to get information out to audiences that need it. And in this case, I'm talking about autism for primary care providers. I should say my conflicts of interest, which are various books and the Journal of Autism, and a couple of foundation grants. So I'm going to say a little bit today about what is autism. This is, again, a very generic discussion for primary care providers. If they're interested, they will hear right now, that there's a whole set of lectures on iTunes U or YouTube that they can go and access, which gets into much more of the details and the weeds on all this. I want to say a little bit about autism as a social learning disorder, something about screening and diagnosis, which is an important and slightly controversial topic, bizarrely enough, and then say something about medical issues and how autism is treated, changes over time, and then some references. So here's the man who first described autism, 1943, who talked about 11 children who came into the world without the usual predisposition to be social, which is really critical for many aspects of what I'm about to say today. He also talked about these were children who had trouble with change. And it's interesting when you think about it, it's actually the basis of much of our work these days. On the one hand, he's saying these are children who have not much interest in the social world, but they're kind of overly interested in the non-social world. And it's trying to make sense out of that, which drives a lot of our research. He thought children were born with autism, and he also was careful to talk about some developmental issues. He actually talked about the work of Arnold Gazelle, who was then here at Yale, and who said that by 6 weeks, babies were smiling back and forth to their parents. And Connor mentioned this to emphasize how this was often autism. The babies weren't so interested in their parents. We actually now know that from the moment of birth, the typical baby is profoundly interested in their parents. So autism, first and foremost, is a social learning disability. And in fact, in some ways, it's a better way to get into it than talking about all the various A words, autism and Asperger's, because it's more understandable to the general population. It shares many characteristics with other disabilities. In general, people don't outgrow it, although they can be tremendously helped, and often are, but not always are, with a realization of what their strengths and weaknesses are. It differs from other disabilities because of its early onset and its pervasive effects. And that's the part of the funny pervasive developmental disorder that was true. If you come into the world with a social learning problem, everything is off in terms of how you learn about the world, and that causes major, major troubles. We know a lot about how autism, actually our understanding of autism has changed over time. In the 1950s all the way into the 70s, parents were blamed for causing autism. Parents was thought that they didn't treat their children right, they were not neglecting them, something was going off, psychotherapy was used. This started to change after about 20 years. In the 1970s, there was a strong brain connection, I'm going to say more about, a strong genetic connection, and also it was discovered that structured teaching was more effective than unstructured psychotherapy, and the first of the various school programs in this country and around the world were started because public schools at that point did not have to take children with autism and often refused to do so. So parents started their own schools. These are schools like Benhaven here in town, the Groden Center in Rhode Island, places around the country that started off because parents were trying to get education for their children. The thing that really changed this, which is really important to realize, is Public Law 94-142, which established in this country in 1976 the right to a free and appropriate education for all children with vulnerabilities. Schools could no longer turn away children with vulnerabilities. They had to educate everyone. This was actually part of a whole civil rights movement. Some of the language is actually civil rights language when you read the law, which has now morphed into something called IDEA. I mentioned some of the brain aspects of autism. This was one of the things that really convinced people that autism was a brain-based disorder. The green bar shows data from Cooper, which is a study of, I think, about 5,000 British, typically developing normative sample of children, rates of onset of epilepsy, recurrent seizures, not just one seizure, recurrent seizures, epilepsy. And the age is less than 3 to 6 years, 7 to 10, et cetera, et cetera. And you can see that for the typical population, onset of seizures is greatest early in life and then goes down, down, down. By the time you're 15 or so years of age, less than 1 in 1,000 children is developing seizures for the first time. And if any of you in this room, and they're probably the mean ages in their 20s, were to develop a seizure for the first time, you'd be worked up the wazoo because people are looking to see what in the world is causing this. It's so unusual. Kids with autism have an increased risk. You see that in both the two light and dark blue bars. The dark blue is from a sample we had here of about 500 children with autism that a medical student followed up with me. And the other is a sample from Boston, Dykins and McMahon. But you can see across the board elevated risk for kids on the autism spectrum. And in fact, an onset not only in early childhood, but again in adolescence, otherwise a very unusual time. I have a lady I've taken care of for many years now who's probably in her late 50s who just had her first seizure a few years ago. And sadly, we don't know much about when the seizure's onset after. This is the sum total of our knowledge really about seizure onset, but it is clear that some people as adults also develop seizures. Genetics, I mentioned, was also a major thing in the 1970s. The first twin study was done by Mike Rutter and Susan Folstein. It looked at identical monozygotic versus dizygotic twins and discovered a very high rate of concordance among identical twins, much higher than the fraternal twins. Over time, many different strategies have been used to look now at the genetics of autism. Tremendous advances have been made. It's gotten very interesting and very complicated and very confusing all at the same time. Autism is clearly a very complicated disorder with many genes involved. Many of these genes seem to have some aspect of regulating either brain nerve-to-nerve connection or something else about brain connectivity. We also know, interestingly, that there's an increased risk for siblings in recurrence. We underestimated this at first. Probably the recurrence risk in siblings is in the order of 10 to 20%. So having had one child with autism, your chance of having a second is increased statistically over the population. I was just down in New York giving a talk and somebody was saying they'd seen a family with 5 children with autism. I said, oh, I know a family with 5 children with autism. Turned out to be the same family. By 1980, there was increased understanding and autism was recognized as a disorder in its own right. It was included as a diagnosis. We also had the first model treatment program start to develop. Over the 1990s, there's been really an explosion of research. The first practice guidelines came out where there was enough information to tell people something about this. This is what the standard of practice should be for looking for screening, for caring for children with autism. There was a great report that came out in 2001 from the National Research Council. I'll say a little more about this at the end, which looked at, it's called Educating Children with Autism. It looked at 10 model programs around the country, each of which had at least one published paper in a peer-reviewed journal to show that the model worked. And there are many commonalities, some differences, but there was a general consensus that early intervention made a big difference. Over time, there's been much more work in terms of research, but also parents have gotten much more involved. Parent groups are now tremendously active. Public awareness has increased also substantially. There are ads on the television. Way back when there was a movie, Rain Man, which was groundbreaking. There's an increased body of work on evidence-based interventions we'll talk more about. And there have been more and more attempts to integrate research into clinical practice. Also, there's been a tremendous emphasis on screening and work with young children. I have to say as an aside, and this is not irrelevant to primary care doctors, unfortunately research, especially on school, but especially on adolescent and older individuals with autism, has really lagged. So there's almost no work on older individuals with autism. There's literally almost no work on aging in autism, sadly. Over the time since Connor's first work, there's been an evolution of the concept of autism as a diagnosis. This has gone through from DSM-3 all the way to DSM-5 in autism spectrum. For primary care doctors, it's probably not so critical to worry about this. Let me say a bit though, why is autism a problem for learning? If you come into the world like most of us do, you have a social frame. You look at the world in the context of other people. You're interested in knowing, what are other people thinking, feeling, wanting, doing? How can I tell people what I want, think, feel, and do? If you go to play the social game, people are the center of your world, you get something called joint attention that kicks in very quickly, that you learn from looking at what your parents are looking at. That's what's really relevant in the world, not everything else. You also have a strong desire to communicate, and you really start to sort out the world starting with people. We know a lot about how the social brain works, and again, for the primary care doctors, it's important only to know that we've identified parts of the brain that are involved in things like face processing, perception of biological motion, understanding of other people, empathy, emotional feelings, anxiety. We've used many different methods to look at this, looking at understanding the face, both through EEG and MRI. I'm going to give some examples of that. Perception of biological motion in MRI, perception of emotion, looking at things like the amygdala and how it responds, and processing social information through things like eye tracking. This is a slide from Dr. McPartland looking at evoked response potentials in faces. And again, you can see that the typical population versus individuals with autism, there's an obvious difference in terms of EEG processing, which speaks to different methods for looking at faces. We also know, and this is a study that was done some years ago here, and which happily has been now replicated more than 20 times, people with autism don't seem to use the same part of their brain, the fusiform gyrus, that the rest of us do for processing faces. And it's a very striking finding. As I say, it works really extremely well and has been replicated many times now. We also know from some work on eye tracking that people with autism seem to look at the world in different ways. This has gotten much more interesting since our original study. Kasia and Fred have looked at this. We've looked at this, and again, people around the world have looked at this. The effect size in our first paper on this was tremendous in terms of looking at the eyes and the face. People with autism, as you see at the bottom, tend to look back and forth at the mouth in this first study, and people who were typically developing looked more at the eyes. This was a very strong, a very high magnitude effect. And again, what does all this speak to? If you don't have the social frame, everything else is important. You don't know how to regulate what is and isn't important. What you get is all kinds of stuff happening, and you have to sort out what does it all mean. So you work for things like contingency. A happens, B happens, A happens, B happens. So you really are resorting to another level of analysis. And it doesn't work so well, sadly. So what does this mean? The meaning sought through connectivity. You have difficulties with multitasking. You don't have joint attention. You have limited incidental learning. You have things like in your voice, persistent odd sounds because you're not interested in processing the sounds that other people are making. This makes for major problems in learning. I want to say a word about best practices. This comes back to haunt us sometimes. I say this is the author of Practice Parameters, also author of a book on evidence-based treatments. There are many levels of evidence. The best kinds of evidence we have in medicine are randomized controlled trials. That's not always so easy to do when you're looking at school programs. Not totally impossible, but it's a hard thing to do. We also like to look at meta-analyses, and if you look at some of the recent practice guidelines from the United Kingdom, they want multiple randomized controlled trials and at least one meta-analysis. And again, that's a lot to ask for, especially at a time when research funding is so little. From that level, we go down to uncontrolled studies, case reports, and anecdote. There are different guidelines that use different approaches. You have to be careful about looking at what their guidelines are. The Brits are very careful to talk about their levels of evidence and what it means. And again, to know that evidence-based medicine is not quite the same thing as evidence-based practice. Evidence-based practice, we need to look at all of the data and the person's values, their needs, and try to sort out what is best for them. That means that we can use things that have perhaps not the strongest evidence because that's the best we got. Also keep in mind that for evidence-based medicine, evidence-based practice, when we look at really well-done studies, we're going to have very strict subject selection. That, of course, throws everything off because in the real world, people aren't that way. You want to do a study of autism and X. Well, you start excluding people with autism and seizures. You start excluding people with autism below a certain IQ. The next thing you know, you've got a very small sample. It's great to study, but it's not necessarily representative of the world. And there is this potential for a catch-22 where we have, for example, an insurance company might say, well, it's not evidence-based. Well, it's not evidence-based because it's just gotten started or we're just doing research. So we have to be careful to have some sense about this. Also, let me emphasize, some studies have never been done, but the intervention is totally accepted. And I can show you one example. This has never been proven to work in a randomized controlled trial. And yet people still do it all the time. If you had the choice of jumping out of the airplane with or without the parachute, which one would you take, right? So again, it sounds a little trivial, but it's not. It's actually profound. Keep in mind there are some things we'll never ever be able to show in a randomized controlled trial. This is going to come back to us talking about screening, which is why I put this in. We know that below age 5 years, children probably have the greatest potential for tremendous gain. The presumption is that for many, although not all, early intervention can make a major difference, and I emphasize not all. Some kids in very good programs, for reasons we don't always understand, don't always do so well, but some do. And for some children, it's night and day difference. We see a child at 2.5, I literally have videos of a 2.5-year-old spinning around my office. By 5 years of age, the child was talking. The kid is now 15 and doing stand-up comedy. There's, again, many issues in early diagnosis. We know that not always are we sure until about age 3, although often we have very strong presumptions. The usual problem we face and work with very young children is the child may have the social and communication problems that we see in autism, but not yet the sort of full-fledged troubles with change, body rocking, etc. The latter often emerge by age 3. Before age 3, we know that we can get services through birth to 3. For primary care providers in this country, they should know that after age 3, the school district will kick it under Public Law 94-142 and its successor IDA until the child is 21 years of age. People know that there are various kinds of screeners. Type 1 screeners are looking for general developmental delay. The American Academy of Pediatrics recommends this at 9, 18, and 30 months. Type 2 screeners are more specific to certain disorders. So for autism, the American Academy of Pediatrics has recommended screening at 18 and 24 months using the MCHAT. That's looking just for autism. We'll talk about what the issues are with the MCHAT in just a second. Having a diagnosis of autism often gets you the highest levels of support from both birth to 3 and the schools. And again, for the primary care provider to realize the schools have the major responsibility for intervention. Now, the problem. The problem is we have somewhat conflicting recommendations at the moment. The American Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatry very recently have said, yes, we should screen. On the other hand, the U.S. Preventive Service Task Force, in its drafted last year, but about to become final, says, well, it's not so clear that the screening works. It's not so clear that we don't have great data on the early intervention. All of it's true and the but is, but you're throwing the baby out with the bathwater. The downside to screening, they point out, is you'll pick up a lot of kids with other developmental problems, which I would say not necessarily so bad. But that's kind of the controversy at the moment. The real problem is picking up false positives. So what do we do? Well, I think it's important to continue to screen. And certainly if I were going to a primary care doctor, I'd want my child or grandchild screened, and I'd want follow-up. And you'd want to share any concerns with the parents, so the parents are involved in thinking about and tracking the issues. And of course, being aware of autism is a problem. So the warning signs from birth to a year, and this is adapted from a chapter Kasia and I did a few years ago. There's some social symptoms, communication symptoms, and restricted interest. This is a relatively short list below age 1. And of course, part of the problem is it's harder to assess things below age 1. After age 1, the expectations developmentally begin to increase. So that after age 1, from 12 to 36 months, it takes me 2 slides to show some of the warning signs. So here are the social ones and some communication ones. And again, you can see these are just in more detail some of the same themes we elaborated early on. And also restricted interests. We have more actual explicit problems in the area of restricted interests. And the other thing to emphasize is regression. Regression at any point in development is a warning flag. And for pediatricians to hear that about 20% of parents of children with autism will report the child has regressed, you have to look into this very carefully, but it's a warning sign that it really should be something investigated. Early screening guidelines, I mentioned level 1 screening guidelines are routine. Developmental screening level 2 is more in-depth for children at risk. And the hope there is to differentiate children who might be having autism from other developmental disorders. There are a number of very good screeners. I have a reference at the end to a chapter that reviews them that's quite current. Some are quite specific to autism. Some are based on parent report. Others on observation. At present, all are paper and pencil. We don't have something like a hearing test for autism, although there's a lot of interest in developing some such. Keep in mind, they all have their limitations and uses as well as their liabilities. The MCHAT was probably the most commonly used. It was developed by Diana Robbins, who was a student here, also a student of Debbie Fines, who's one of the co-authors. It's a 23-item checklist. It best discriminates at 24 months. The items that especially discriminate are the proto-declarative point, showing something. I want you to see that clock. Responding to name, interest in other children, bringing objects to show, following a point, imitations, social smile. One of the things that's really important when a child screens positive is to do follow-up. The trouble with the MCHAT is it gives many false negatives. It has a higher specificity. Even there, it misses some children. And again, it's for complicated reasons. Sometimes the child is higher functioning. Sometimes the child regresses. Sometimes the parent report is off. All those usual things. And I should point out, by the way, that there are many problems even when people use this. There was a large study from California looking, I think, at 17 pediatric practices. Even when kids scored positive, about 60% of the time, nothing ever happened as a result. Things fell through the cracks. The parent was told to contact birth to 3, but they didn't. Or they contacted birth to 3 and birth to 3 didn't call back. So keep in mind as well that it's important for the pediatrician or the primary care provider to be sure there's follow-up if a child does screen positive. There's a new version of the MChat that's relatively shortly out. It has low, middle, and high risk groups. The middle group is the sort of tricky one in terms of knowing what to do. There's a nice study on it. And again, it's better done than the earlier version of the MChat. It still requires a certain amount of thought clinically when using it, but it's important to have some screener out there that you're positively using. We have new approaches that are in the offing to develop screening methods. These would use things like EEG, eye tracking, listening. These have many potential advantages. The problems with these at the moment, and Kasia, who I know is unfortunately sick today, so she's not here, could talk about this in some detail. The problem is most of these studies are being developed using high-risk samples. And if you have a high-risk sample, if you're looking at siblings who are developing, you're basically fishing in a stocked pond, as they say. And so what we need to do is take these out into the real world, which is always the problem with treatments and methods developed in clinical settings like this research one, is to go out into the real world and say, okay, how well does this really work? And not just in the general population, but children with developmental disabilities. And people know that we're very aware of these issues as we look for new approaches to screening. There are a number of other screeners available. I've listed a couple here. These can be used. They require various levels of training. I also would emphasize, and I'm not talking about it in this talk, there are also screening approaches for older children, adolescents, and adults. And we do occasionally have children who come in who've never been diagnosed, who are school age, even older. And there was a recent study at, I think it was Virginia Tech, looking at a large sample of undergraduates, just basically literally pulled off the street. About 1% to 2% of them screened positive for autism, either on the SRS or another autism screener. So there probably are cases that are indeed underlooked. Parent perception can impact screening. It's not diagnostic. Having a positive screen does not mean you necessarily have autism. It's a problem also for many primary care physicians and providers seeing children in highly unusual settings like the pediatric office. You're not going to see representative behavior. Either the kid's going to be a mess and out of control or totally withdrawn and bonkers and waiting for the next shot. It's a problem. And that's why it's good to get parent report, but keep in mind that all this has its limitations. Parents who are more educated and sophisticated may see more. They also may report more. Parents who have less education, less aware of autism, may not appreciate what's going on. There's good data on that, sadly. In terms of what we want to do in terms of an assessment, we want to have a history for everybody, looking at pre-perinatal developmental histories, how the child's doing at the moment, the family history. Are there other people in the family who have autism, other developmental problems, other psychiatric issues? It turns out anxiety and depression are often seen in family members. And regression, as I mentioned, is always a warning sign that should prompt more study. Initial assessments, there are practice guidelines that actually give very specific recommendations. Basically, you're looking hearing and vision, dysmorphic features, the genetic degree of genetic evaluation, as people heard recently when Abba gave a talk, is an area of some controversy at the moment. Any dysmorphic features, especially with family history, should prompt a more in-depth genetic assessment. Also be aware of the more frequent medical problems, seizures, and a couple of associated medical conditions, Fragile X, tuberous sclerosis, and there's a host of other things that are kind of kicking around at a very low level of the genetic variety that also you need to be aware of. In the history, we'll look at the pregnancy, labor, and delivery, developmental milestones, family history. As time goes on, we want to hear about interventions, medical interventions, complementary and alternative treatments, and what's happened to the child over time. Have there been major changes, regression, or moves to the better? The two times you hear about changes, major changes, early childhood and again adolescence. Some kids in early childhood take off, others don't. Some kids in adolescence take off, and a few, sadly, a few don't do so well. They go the other direction. Physical exam, again, you're looking for genetic any conditions that might go along with Fragile X, tuberous sclerosis. So unusual physical features on exam, any dysmorphic features at all, questions of seizure disorder, head size. And the interesting thing about head size, which is seen, macrocephaly is seen in a minority of people with autism, and Kasia's work has pointed out that it actually may be a more generic problem, not just head size, but body size as well. These are big kids. Laboratory studies, lead level, the genetic testing I mentioned is going, genetic testing has gotten very sophisticated. What used to be extremely expensive and complicated has gotten much cheaper, but not totally inexpensive. It's guided by history and exam, and the recommendations from the American College of Genetics are published. They do not endorse the current commercially available gene panels, which is probably important for pediatricians to know. None of the practice guidelines, by the way, also endorse things like hair testing, the vitamin business. There's just not evidence for it. And EEG only if the history suggests regression or signs on physical exam. Neuroimaging, interestingly, does not yield much payoff on a routine basis. Obviously, if there are indications, yes, but routinely, no. The 20% of seizures, the risk persists into adolescence, Fragile X, tuberous sclerosis. The yield, when you start doing very sophisticated testing genetically, is about 10% at most. Sometimes this is uninterpretable, and sometimes it has real importance for the family. Hearing and vision screening should always be done. The medical home is something that's been recommended by the American Academy of Pediatrics, especially for children with special needs. It suggests there should be a care program that's comprehensive, coordinated, accessible, family-centered. People should know what they're doing. They should know about resources. There should really be a resource for the family. For children with autism, unfortunately, care is often very fragmented. They have trouble getting services. They have trouble finding primary care providers who have good knowledge. They often use the emergency room as a resource. They fail to look at the big picture. So, for example, it's easy to skip dental visits. Dental visits are one of the easiest things to skip, and you often pay a horrible price in adolescence as kids start to have general anesthesia to have dental work done of any kind. And that's also a problem when dental problems really kick in a major way. Comprehensive assessments, this is the kind of thing we do here at the Child Study Center. This is not something the pediatrician or the primary care provider would do in their office, but we're looking at doing a developmental assessment or an IQ test for an older child. We recommend speech communication assessment as part of an exam, psychiatric assessment including diagnostic instruments. The latter do not replace ever good clinical judgment. I was just talking to Kathy Lord about this, we were agreeing about a case that, you do the instruments, but then you take a step back and say, okay, what does this tell us about this child? Other things like neurological and medical and other professionals like occupational and physical therapy can be very helpful. The label is important in this country because it helps to get services. States vary somewhat in terms of when you have to assign a specific diagnostic label. Educational labels differ somewhat from medical labels. You can have very generic labels like other health impaired. Or in this state, you can have developmentally delayed. I think it's still 6. Karen will know. 5. Other states, it varies the age in terms, you can just have a generic label. The good news is you don't have to label a child, you don't have to say autism. The bad news is that should not become a reason for not giving services. And so that's the discussion about the autism label. Schools are mandated to provide services. Autism is specifically mentioned as one of the handicapping conditions. State requirements vary, I say, widely and wildly, and that's absolutely true. One of the sad issues in this country, we spend a lot of time, we think, collecting data. Nobody can tell us what's going on between the 50 states. It's hard enough even within a state. The Medicaid data from state to state is almost uninterpretable. And it's a shame because we really have 50 different experiments going on in the 50 states and we don't know. Medical care issues. Well-child visits are very important. It helps the child and the staff become familiar with each other. You can make visits go better by having visuals, books, schedules, and again, there's a whole set of resources that you can find online for this. They help by making the setting familiar. You can have the child go and spend time even when he's not necessarily going for being sick. So that's why, again, why well-child visits are helpful. For the physician or the nurse practitioner, keep things slow, keep language simple. I'll talk more about that in a second. Same thing with dental visits. And again, there's a little resource online, the same group of lectures on autism for dentists that may be helpful. Having a medical home, does it make a difference? Well, in fact, there's a number of papers out now over the last few years that says it makes a big difference for kids with autism. One paper shows that there's better coordination of care. People tap into more and more relevant services. Another paper looking more generally at children with developmental disabilities in medical home settings says it actually decreases the number of emergency room visits. People are less likely to use the ED as their primary care place. One study says there are fewer unmet needs. People feel like they're getting services in a medical home. In that study, only 20% of the sample were actually in a medical home. And as Hyman has pointed out, there are many challenges to providing this. This is not something that's necessarily easy to build, although there have been efforts to actually provide extra reimbursement for providing a medical home model of care in the primary care setting. Again, we talked about picture books, apps, social stories, thinking about scheduling, having the kid be the first appointment in the afternoon or the morning as opposed to waiting. Waiting is not a plus. Having favorite activities with, using the iPad to show the doctor's office ahead of time, the staff. Save more intrusive things for the end. Ask for help from schools and parents in terms of what works well. And again, there are a number of resources that are now available, interestingly enough, a whole set of books from the Royal College of Psychiatry on things like having your first GYN appointment, picture books, so that you can go through ahead of time so the child knows what's going to happen. Technology is extremely helpful on this, both low-tech pictures, schedules, other kinds of things, but the apps, the mini apps for the iPad and the iPhone can be really helpful in terms of showing the person what's going to happen during the doctor visit, who's the doctor, what are they going to see. The common problems you see in terms of what gives people grief. Kids with autism have problems with organization, so you can be stepwise, you can be consistent, you can do the same thing every time. You use routines, you use visual aids, you give plenty of time, you give visual cues. We've got 3 more things to do, 2 more things to do, 1 more thing, and we're all done. Isolate information in terms of attentional skills, saying this is I need to listen to your heart right now, showing people, giving supporting attention, having things again visually predictable, using visual learnings and supports, keeping language simple. One of the problems for all of us as we talk to people who are getting anxious, we tend to get polite. When we get polite, we tend to use things like subjunctives, could you, might you, should you, and that's bad. We want to keep things simple. Stop now, I'm doing this. Don't go through a whole big package. Keep the language simple and straightforward. Again, people with autism tend to learn things in chunks. That's one of the reasons they often echo language. It's their style of learning is to learn the whole thing as opposed to breaking it down. So having the family involved, having them play at home with things, knowing about playing doctor, listening to the stethoscope, having a sense of what's going to happen, making things familiar as opposed to anxiety-provoking. And again, in terms of time, temporal cues, giving very straightforward feedback, showing timers, all kinds of things you can use to help, keeping things simple socially, understanding that social cues may be very hard for kids to take in, but be very explicit in terms of what you're going to do. One of the important things for primary care providers for all children is helping parents around safety issues. Accidents are the leading cause of death in this country of children, and that same thing is true for kids in the autism spectrum, except the rate is double. The highest accidents occur early on, poisoning, other kinds of things, but you have the combination of good motor skills and poor judgment and odd interest in responses to things, so the kid may eat something or drink something other kids wouldn't. There's about a 40% risk of bolting, children who run out of the house. We've had several sad examples in New York City of kids who bolted from school and were found in the river. Drowning is the most common cause of death. So you want to safety-proof the house, be prepared for problem situations. Everybody should learn to swim. For some children who really have a tendency to bolt, having a good behavioral psychologist who can consult around that, also having tracking devices. There are things you can have the kid wear now. You can have a little thing the kid's got on their arm or wear around their neck, but something that you can use to find the child. Also a medical alert bracelet that says what the name is, I am autism. But again, things like that, thinking that safety is a real issue. Sleep problems are extremely frequent. More than half of people with autism will have a sleep problem that lasts more than a month. The common problems you see, people don't have good what's called sleep hygiene. They don't have good bedtime routines. They often, unfortunately, because of their peer issues, lack exercise. They don't have the same amount of exercise other kids do. They can have side effects of medications that can throw off the sleep cycle. The kinds of things you can do is you can keep a sleep diary. In fact, it's interesting. Parents often find they underreport how bad, in fact, the sleep problems are. There's some very good resources. There's a great book called Sleep Better by a man named Mark Durand, who's a behavioral psychologist. It's a great book on teaching sleep hygiene, looking at some simple things like increasing exercise, decreasing naps in the daytime, looking at the medications, having a very explicit sleep routine you go through with a child, having rituals around nighttime and getting the kid to sleep. Eating and GI problems, these are very commonly reported. Unusual food preferences and sensitivities as kids get older. Obesity is a major problem. These are kids who tend to enjoy food because it's one of the few things that they can get to. And sadly, because they're socially isolated, they often don't have the peer interaction, they don't run around. They can have problems with eating non-nutritive substances, pica. They can have constipation, again, because they're not moving around so much. There are many dietary interventions out there proposed. The evidence actually is quite weak for these, unfortunately. The gluten-free, casein-free diet has been evaluated, as have been vitamins in a couple of studies, and there's just not information to show that it works. There's a good double-blind study that's just coming out, if it hasn't come out already, in JAD, a challenge study looking at gluten casein-free diet. It didn't see any difference. And there's no evidence that GI problems are unique to children with autism. Dental care, again, starting early. People tend to avoid dental care. All of us avoid going to the dentist if we can help it. But preventing cavities, even simple things like fluoride, teaching about toothbrushing, finding a good pediatric dentist who will deal with a child with special needs is important if you can do it. If you don't, then the trouble hits you in adolescence, often requiring general anesthesia. One of the commonest signs of dental problems in adolescents who are nonverbal is face slapping, because what's happening is they're getting impacted wisdom teeth, or wisdom teeth are coming in, but they're either having dental caries. But self-injurious behavior with rapid onset is often a clue, either for a ear infection or dental issue. Preschool issues, medical issues have to do with finding a medical home, getting services, screening, getting a diagnosis. The transition from preschool to school programs can be somewhat tricky around age 3. Behavior problems can start to increase as children get a little older. It can be more hard to manage. What's cute in a 2 or 3-year-old and a 5 or 6-year-old may no longer be cute, and it may be quite problematic. Under 5 years, I mentioned, is the time for the child to make the greatest gains. Kids continue to make gains after that. Sadly, not every child makes gains, although some do, many do. By school age, we're talking a lot about preventive care and routine visits, dental care, vaccinations. We want to look for things like obesity, side effects of medications, which can sometimes contribute to that, safety issues, and this is a time when bullying starts to kick in. About 40% of children with autism in this country report, or apparently involved in bullying in some way, being bullied themselves, doing bullying sometimes, or both. That's about double the national rate, which is about 20%. If you're a person with autism and you have other problems as you go into adolescence, your rate of bullying may be as high as 75 to 80%, which is fairly tremendous. As I mentioned, adolescents and adults, we have relatively little information in terms of medical management issues, and we have basically none on aging. We do think that probably the use of medications, which sadly is frequent and sometimes over-medication seems to be the rule as opposed to the exception. I think there was a study done some years ago looking at Medicaid populations, I'm going to say in North Carolina, and I may be wrong about that, but as I recall, the typical person was on 3-something medications. And by the time you're past 2 medications, it gets really hard to get involved. Medications for behavior. Hypertension starts to increase. Interestingly, among the more cognitive able students we see in college and beyond, adolescents and young adults, there's an increased risk for anxiety and depression, and I mentioned the bullying. This is all, unfortunately, often a package together. There are also, sadly, issues with insurance coverage and support, especially as children age out of their parents' insurance policies. After age 26, many folks have to go on Medicaid because that's all they're eligible for. Drug treatments, we have, interestingly, a major placebo effect in autism, which people didn't, including me, didn't think we had until we did the studies. This was because we looked at a drug called secretin, which was a gut hormone. People were sure cured autism. There are 5 double-blind studies, very quickly done. Secretin worked no better than placebo, but placebo worked pretty damn well. And you say, how could that happen? Well, of course, what's the placebo effect? People are paying more attention to the child. They're expecting more from the child. They're involved. There's expectancy effects in terms of being involved in a study. People's behavior gets better. That's great news. That tells us we can do a lot, even without the medication. But to have a really effective medication, we want to go past that. And there have been a couple of groups of medications, I emphasize only a couple, that have really been looked at with in some depth and detail in autism. Risperidone and another one of the newer generation, second generation neuroleptics have been looked at, and they work pretty well and quickly. The SSRIs are used more for anxiety and depression and to some extent rigidity. They seem to work somewhat less well than children, but better in adolescents and adults, and there have been several well-done studies in adults. As with any medication, you always have to worry about the side effect profile, balancing the risk and benefit. This is the first RUP study looking at risperidone. This was a double-blind, placebo-controlled study, and what you can see here is by 2 weeks, there was a significant difference between the groups. This difference continued, and even continued after the risperidone was stopped, for I think 6 months follow-up. Now the trouble with risperidone, Sedation is a major side effect, but especially weight gain. It directly stimulates appetite. And so again, you got to balance because you've already got a population at risk for obesity. And this helps with irritability. So this is helping people who are irritable. And it's not very specific, certainly to the major issue in autism, which is the social problem. And that's something people, the drug companies especially, are targeting right now along with other researchers. Other medications are really used to treat associated conditions. You can use stimulants for attentional problems. They work, but they have probably a higher rate of side effects than in the typical population. I mentioned anxiety and depression, the SSRIs. Keep in mind cognitive behavior therapy can also work for anxiety and depression, and we have good data for that, and we have modifications of CBT specific to children, adolescents, and adults with autism. The mild sedatives can sometimes be helpful. You have to be a little careful because sometimes you'll get a paradoxical response. The person will get much more agitated. So if somebody approaches me as a parent and they want some medicine to help a child get through a dental visit, I'll say, okay, we're going to try Ativan. Here's the dose. I want you to try one dose at home to see what happens first. Caveats. Don't treat a bad program with medications. That ain't going to work. So always ask about the program. Be aware of the side effects. Also be a little bit of a detective yourself. This is probably less for primary care doctors and more for people like me who get into talking about medications in great detail with parents. If you hear, for example, a woman talked to me not too long ago about her child, and she said Linda was having trouble on the bus. And she wanted medications. And I said, only on the bus? Only on the bus. So what are we talking about? We're not having a medication discussion, we're having a bus discussion. And they had put somebody on the bus who was a screamer. This kid did not like sounds. So it's a bus discussion, it's not a medication discussion. It's what can you do about the bus? Vaccines and autism, for primary care physicians especially to know, there's no evidence that vaccines cause autism. There's no evidence that thimerosal, which is used in a preservative of the vaccine, which has now been taken out of, I think, everything except multi-dose influenza. Many parents are now avoiding vaccines because it's got an extreme popularity in terms of vaccines causing autism. There's absolutely no data to show that. We know that there's an increased risk if you're vulnerable to things like measles, chickenpox, measles, mumps, rubella, and people are starting to see cases increased around the country. Well, we had our first case in Brantford not too long ago. My wife, who's a pediatrician, she and her older partner are the only people in her practice who've ever seen a case of measles. And measles used to be it was gone. Well, it's now making a comeback for just this reason. Let me say a word about complementary alternative treatments. By definition, they're not proven treatments. There's a little data, mostly anecdotal. They're very frequently used. Complementary means in addition to something that's been proven to work, good school program. Alternative means instead of, and that's where you have to be really careful. If parents are pursuing treatments that have not been shown to work, and they're doing it at the expense of treatments that have been shown to work, you really have to get nervous. Sadly, there are limited sources of information for parents and professionals on these. People have been making an effort in recent years. There's a good chapter in the Handbook of Autism on complementary treatments. There's a good resource online. Sadly, it's called Quack Watch, but it'll give you some information about complementary treatments. There's also at least one or two now books on the topic that provide more, just descriptions of the treatment, what the evidence is, pro and con. So it's a way for parents to get information. There's a lot of information out there on the internet that's unfortunately not very high quality, which is why we're trying to do videos like this. There are a couple of books. I mentioned the Controversial Therapies for Developmental Disabilities. More and more of the practice guidelines are specifically talking about treatments and saying what the level of evidence is. Now keep in mind, something can be, you can pick any topic. Let's say music therapy. Music is great, piano lessons are great. They can be therapeutic. Now in terms of the therapy part, there's very limited data. That doesn't mean you can't do it, it's just, it's a choice. But don't think it's going to cure your child's autism. So again, it's that kind of issue that things can be helpful, but you have to have a little bit of judgment of this, and it's easy to kind of go overboard very quickly, unfortunately. We talked about autism interventions. We're getting towards the end. I mentioned the big change in 1975, Public Law 94-142. Autism has to be treated in schools. And we've now seen that planning appropriate intensive interventions for social difficulties can make a big difference for many children. I mentioned this report earlier from the National Research Council. It went through all 10 programs in the country at that point that had data, talked about the similarities and differences. It recommended on balance for preschool children about 25 hours a week of programming. This could be in the home, it could be in a center, and again, there are lots of shifting sands in this area. But this was a very influential book, and we were just talking about writing a commentary on sort of what's happened in the years since this volume came out. But the book says basically this: autism is a disorder that impacts development, interferes with learning. On the other hand, development happens. From the point of view of treatment, our strategy is this: we try to minimize negative effects autism has on learning and maximize as much as we can ways for children to learn from the world in more typical and more efficient and effective ways. And that's the secret. That's easier said than done, but that's it in a nutshell. And the good news is we are seeing some differences in terms of outcome. I emphasize I'm cherry picking these data. The first set of studies, good, fair, and poor outcome. The first studies, good means you're independent and self-sufficient as an adult. Fair means semi-independent. Poor means you're in 24/7 residential care. And you can see the first set of studies started with, I think, Leo Connors in 1956. Kids did not do well. About 5% of kids on average had a good outcome. And then you notice I stop in 1974 because I'm stopping as Public Law 94-142 kicks in. I wait 15 years and pick up the next set of studies, and look what's happened. We're seeing more kids have a good outcome. We're now having kids go to college. This is a new problem. It's a happy new problem to have. I've had a student in my class, as has Dr. McPartland, who self-identified as having autism, which is, again, that's great. It's a new problem. But it's a great new problem to have. But we have to think about what are we going to do to be able to accommodate their needs. So I want to close. We have time for a few questions. I mentioned the FAR Fund and the Mann Foundation, the Associates of the Child Studies Center, the university, which does a great job in supporting people like Guy, who's filming, and his office and all my colleagues whose work I'm drawn upon for this presentation. So thank you very much. We'll have time for questions. Whoops, I got my GIF file here. So I want to end with a Yale Bulldog. So thanks, and I hope you haven't been put to sleep. And let me just put up for 1 second the first set of references, then I'll put up another set of references. So thanks very much.